All right, well, we are safe distance away, so I'm going to take my mask off and join you a little bit. First, I want to welcome everybody watching at home. We wanted to take an opportunity to talk to Dr. Darren Brucken, who is a doctor here in town and the health commissioner of the Vigo County Health Department. Dr. Brucken, why don't you tell us a little bit, you said that you had just kind of an idea of where you get your information. Maybe that's a good place to start.
Okay, yeah. Well, so I have a unique vantage point about COVID-19 because of overseeing the health department. I've been part of all of the contact tracing from every single case that's been through our county, number one. Secondly, I'm interacting with the health department, the Indiana State Department of Health, been very interactive with school systems, not only secondary education and even elementary, preschools, you name it, kind of been there. And then lastly, I'm a practicing physician. I just came from the hospital after a 12-hour shift, so I do critical care. I do internal medicine on the ward, so I take care of COVID patients. So I've been very much involved from the get-go of COVID-19 in the entire area and as it's come through. So I've had patients, I've taken care of them, I've had those tough conversations with them and their families. It's a horrible, lonely disease. It obviously kills people. I've been there as people have taken their last breath. And I've seen, I'm interacting with people every day in the community. So to be able to kind of focus in on the medical aspect of things, the public health aspect of things, the medical research, the virology, the epidemiology, it gives me a unique vantage point. And so it's, I think I'm probably as prepared as anybody to field these questions.
Great, great. Well, I introduced you, but I didn't introduce myself, so I'll do that now. I'm Bill Riley. I'm the Director of Communications with the Vigo County School Corporation. I want to start this conversation off. You kind of discussed where you're coming from on this virus. I want to discuss also where I'm coming from so people understand. First of all, I also believe that this is a serious virus and it's real. I think that has to be our starting point for our conversation here tonight. I'm the parent of a child in our school corporation. But I'm also the son of a teacher, not in this school corporation. My mother retired 33 years as a second grade teacher. So I want to also point out that I understand where teachers are coming from a little bit. So what we did is we put out a call for questions. We got several questions, over 70, 80 questions. We are not going to ask you every question tonight after your 12-hour shift. But as we said, I'm committed to asking you a range of questions and maybe some not so easy questions because as we know, there aren't any easy questions with COVID. But I want to start with the data from the Indiana State Department of Health dashboard yesterday, which said that in District 7, which is our kind of county, 5-6 county area, there's a 4.5% positive rate. In Vigo County, as of yesterday, that positive rate was 4.1%. We're talking about coming back to school with that number. And, we're not alone. Other districts across the state and country talking about coming back. In Indiana, there are some counties with 8, 9, 10%. Some are going virtual, but some are coming back to school. One question that came up often was, with cases rising rapidly, and they are spiking in Vigo County, is it in the best interest of our community as a whole for schools to reopen to in-person instruction? This person said, I'm concerned that this will impact our community even beyond those directly tied to the school corporation.
Yeah. Well, first of all, I want to make one statement is I'm not privy to these conversations yet. These questions are coming at me blind, which is great. This is how we wanted this to interact. So I want to answer things as openly and as reactively as possible. We all are, we're all crunching numbers. We're all looking at these data points. But we're watching the community numbers rise. The positive percentage rates are rising, and schools aren't in session. So how is that going to impact us when they do? And what do we attribute that rise to now? Is it churches? Is it bars? Is it restaurants? Is it family outings? Is it travel? It's everything. You know, we're seeing the numbers go up. So then we have to look at, all right, society is open, and I will take one giant step back real quick just to state I'm my own resource here, okay? So there's a lot of editorial from me. My opinion is out there, and that's where a lot of this conversation is going to originate from, just kind of so you know. So we look at, you know, where is it happening now? We see it happening from pool parties and house parties and bar exposures and, I mean, you name it, churches coming together, family reunions, travel in and out of the state, people traveling to locations and coming back here. So we look at the risk and reward of going back to school. You know, we in public health, we anticipate the numbers will go up a little bit because we're bringing people together. But as we also look to other parts of society and we're bringing people back together, those events that we can control the variables, we can control those idiosyncrasies that spread disease, social distancing, masking, regimen of just strict attention to detail, we can mitigate that to an acceptable level. And when you look at, you know, the benefit of the bars being open, of course there's a huge economic boost for the bars. I love bars and bar owners. I'm not trying to make enemies. But the reward of going out to eat and out to a bar is just that. It's a social reward. We look at the reward of getting kids back in school, in-person instruction, not only nutrition and supervision and structure and education and social interaction, these massive benefits for these kids is far outweighed by the limited risk that we are all willing to endure from a public health standpoint by bringing kids back. We do not anticipate this will be a bump-free road. We'll hit a few potholes along the way. I think everybody is aware of that. When we look across the state, we look at all of these institutions and these school corporations that are coming back saying we're virtual only. That's great for some people. It is not great for Vigo County. You know, we have to have in-person teaching. We've got to get these kids back in school. And the reward of that is immense compared to the risk of bringing people back. And because of the attention to detail with controlling these variables, it can be done safely.
So this is a question from Mandy Jeffries, a parent, kind of along the same lines. We initially closed schools with just 4 confirmed cases, and I didn't fact check that. That is the question. Has there been any discussion about what point schools will close again? I have seen other plans from other school systems that give a clear and definitive threshold. Is there a building closure metric that has been developed or will be developed should cases continue to increase as they have been? I think the heart of this question is, when does that risk reward tip from a public health standpoint?
Sure. Yes and no. Those strategies are in place, but it's a case-by-case basis in that we're going to examine every single case. And we will have positive cases in schools. It's not a question of if, it's a question of when and where. And we look from a public health, I look internationally. I look at European, I look at Chinese data, I look at all the Asian studies, the Korean studies, to try to figure out, what is that best response. When we were in the midst of the pandemic, when it first hit and the word came out, we are closing schools, that is a move for immediate isolation as a mitigation process. Once you're through that process, now we're talking about a planned reopening. So they took away a situation because schools were in session at that time. There was no planning. There was no control of variables. The best thing to do at that point is call a timeout and get kids away from school and away from each other, while everybody regroups and figures out how can we do this safely. Now it's time to put that other piece back into place. There is, in my mind, there is no one set number that's going to say, boy, if we hit 10.6 on this scale, we're going to shut everything down. I don't see that happening statewide. I don't see it happening from a federal standpoint. Certainly don't see it happening locally based on one little entity or one number. But that said, this entire plan, just like all of the COVID response, is all fluid. Everything has changed and evolved, and it will continue to change and evolve in response to circumstance. We cannot predict the future. If a elementary school suddenly has 60 cases, and we look, and geez, 60 of those kids, they're really sick, and we've got 2 sick teachers, that may be enough. It may take one case in one school to be enough to react immediately to say, we need to look at this. So we're moving through it, apprehensively, cautiously, but also expeditiously to that endpoint of we're going to try to do things as safely as possible. We're expecting the bumps as they come. And every single case will be looked at individually with a pretty keen eye.
Well, this makes a good transition to my next set of questions. So we got a lot of questions about our exclusion policy, which, by the way, is in our plan at vigoschools.org. There's a chart kind of in the middle of the plan, but we had a lot of questions about if my child tests positive, does the whole class have to quarantine? If my child or children are exposed to a positive child or teacher, will I be required to quarantine as well? I think the heart of these questions are really about how contact tracing works to exclude higher risk individuals. Can you kind of tell us a little bit about how contact tracing works, how we've already worked with you on contact tracing, and how things like these masks, distancing, they work in a contact tracing setting?
Okay. This all goes back to the rudimentary science about how this virus spreads person to person. And this is a host-to-host transmission. I'm going to grab my water bottles here because I want to show people kind of what this means. My props. If we have a COVID positive patient represented by the green bottle and we have someone who is uninfected, okay, in this case, the COVID green has to get from here into here to cause problems, even potentially cause problems. We're not talking about symptomatic, pre-symptomatic, asymptomatic, just virus to here, it has to get here. So if we look at these caps, as these are our masks, if we take our mask off and we slide these two things together and we shake them up, there's a good chance this is coming in contact with this can become infected. That's the generic principle. Separate so that whatever's going on over here is not affecting this. This is social distancing to keep the spread from here to here. These are your masks. This guy who is infected wears a mask so that when things are sloshing around, it's not coming out on the particular matter around, and it's also not getting over here. This guy may not know that he has a drop of green in him and is pre-symptomatic. He wears a mask to protect everybody else around him. This is the concept of universal masking. Yes, there, without question, is benefit to this guy as well to keep from getting splashes of green over here. Regardless if it's 100% successful or 40 or 20 or 12, it's better than zero, okay? So this is the generic principle of social distancing and masking. Contact tracing. If we have these guys here and these guys here and no one's wearing a mask, these two are going to spread disease to each other just out of proximity and interaction. The person who's way over here is probably not going to have any problems, particularly if they have a mask on. So we look at contact tracing to say, okay, here's our positive. We're going to call him Bill. That's you. Bill, who were you sitting next to? We go to Bill's teacher. He says, well, I was sitting directly next to this teacher, A, B, and C. So now we have their immediate contact, their circle of friends that they're with. This pod of kids move around, they go to lunch together. This pod of kids, if possible, sit next to each other on the bus. We know the immediate contact, okay? We don't have to worry about this guy over here nearly as much. So we look at contact tracing to try to stratify risk. These are high risk, this is low risk. If we have a population of 30 in here, we can isolate 4 kids in a ring of high risk, moderate risk, even high risk, or whatever, but we can exclude everybody else, which means, no, we're not going to shut down an entire classroom. We don't have to cancel Mrs. Jones, their entire 4th grade class. We can just look at the contact tracing and figure out now what was the risk individual. How symptomatic was COVID Bill here? How symptomatic, or what's the exposure risk from here, okay? And it spins into a bigger concept about symptomatology. Not to take a lot of leeway here, but the symptomatology of a kid means a lot. And asymptomatic and pre-symptomatic, these are the newer catchphrases that are coming out, particularly pre-symptomatic. Those are people that have positive viruses, it's in their body. They don't have symptoms yet, but they will. So they are pre-symptomatic when they have the virus inside of them. They can transmit all around them by large aerosols, by fine aerosols, by fomite transmission. They are capable of doing that. The asymptomatic, those are the people that may test positive for the virus, and you're like, I can't believe I'm positive. I have no symptoms, and they never develop symptoms. Those are perpetual asymptomatic people. We are not seeing a significant number of asymptomatic spread in our community and other communities of kids internationally. And that's what owes a lot of confidence in the fact that we see a lot of this in kids. We see a lot of asymptomatic kids. And we don't see a lot of kid-to-kid transmission. We don't see a lot of kid-to-parent transmission when they're asymptomatic or even minimally symptomatic. That's wonderful, because if you can monitor for symptoms, you have a symptom-based strategy about being in school, perfect. That's great. Test-based strategies that say everybody has to have a negative test, that is a point in time, and that is pointless. We have to be monitoring for symptoms. So if this person is exposed to someone asymptomatic, they have a mask on, their risk of transmission is minimal, negligible almost. So if we can say with certainty, we control the variables. They wore masks in passing periods, they set as distances we can make them, and when social distancing wasn't possible, they were masked. We have a low level transmission risk. This kid doesn't even need to miss school.
You talked earlier about the reward of having school and how it outweighs the reward of doing everything else in our society, really. I think our kids and our families need school, is what you said. It strikes me that everybody, the adults, the children, need to be able to do the things that they need to do within our plan in order to protect that. Is that
Sure.
fair?
It's a global statement, the masking mandate that has come down, the purpose of me wearing a mask is if I'm pre-symptomatic, if I'm even positive, maybe I know that I'm positive, or I'm symptomatic, I'm coughing, sneezing, I'm blowing things out of my nose, and I think it's allergies or whatever else. If people across this area would all wear a mask, okay, so I've got mine on, and now I cough or sneeze, it is caught, it's trapped here, so I have effectively prevented the spread of my particular material, not only right here around me, but also anywhere in my immediate vicinity. And if everybody has done their part, if we can contain virus into those people that are already infected with the virus, where it's living in that person, it dies inside of that person, and it cannot transmit itself. It's not going to lay dormant for 9 months and then suddenly reappear person to person. Once it has been mitigated to a point where the infectivity has died down, we're home free. That's what's so frustrating about this from strictly from a medical standpoint. When things like Ebola comes out and we have these outbreaks, we quarantine, we contact trace, and we isolate, and it burns itself out, and the losses are minimal. We do not say, well, let's just go back in and just do whatever, let's just all, play together, no mask, don't worry about it. That's exactly the opposite of what we do. In reality, what's going on now is, we don't see enough masks. We don't see enough attention to detail about controlling those variables of being close in interpersonal spaces, and even following through with quarantine instructions. Hey, you had an exposure, you need to stay home. And we find out that's just not happening. And it goes back to our contact tracers, and I can't express how difficult it is for our contact tracers when they call and they speak to somebody about their contacts, and they're told, yep, it was just me and Joe Blow over here. And we call Joe Blow and says, that's absolutely right, it was just me and him and 4 other guys. And then we call one of those other guys, yep, it was just us 12. And then, yep, I went to work, and yeah, I don't have COVID, but I'm coughing and have a fever. And that's what we're dealing with. We're trying to trace these people back. But the diligent effort that we have put forth through the health department, through our contact tracers, is we have been able to identify with great confidence that people that are picking up virus, they're getting it from symptomatic people. Whether they're currently symptomatic, the timeline matches up, we know that they're getting it from there. We're not seeing people that just randomly get it, and we don't have any idea where it came from. We don't see that in great proportion. We're at 388 cases, now in this area, in this county, and counting rapidly. So if we can continue our contact tracing, we propagate that within the schools, and the schools have all pledged they are going to be very diligent with helping us do these things. We can control an outbreak even within a building, even within a classroom, even within a bus. You know, the variables that you guys can't control very well, they're gonna show up over time. And maybe that's recess, maybe that's lunchtime, maybe that's passing periods, maybe that's the logistical demographics of an actual classroom, but just not big enough. And we just gotta deal with those as they come up.
So 2 weeks from tomorrow, we're set to start school. The message from you is, let's wear a mask, let's knock this thing out
Yeah.
as a community, and, you know, have a bit more confidence about our return to school
Yeah.
activities.
Yeah, and personally, as I said earlier, my own editorial, my own opinions, but they are rooted in science. They are rooted in the research and the diligent efforts to try to track down. I'm actively going out, I'm searching for things to debunk these theories and for any evidence to the contrary to think, well, I'm just not thinking about this correctly. My confidence is very high that the kids are going to do very well as far as coming back to school. And as far as, yeah, we'll have our isolated transmissions and things, but as a whole, the greater good is served, and it's going to be served as safe as possible across the board, kid to kid to kid. We'll put the other variable in, teachers, and teachers' aides, and cafeteria workers, and custodians, the older adults that are intermingled amongst these kids. They're more susceptible to illness than the kids are. The kids have been vigilant against this across the board, which has been wonderful. They can endure exposures. They do great. Older folks, people with diabetes, obesity, hypertension, heart disease, asthma, lung problems, there's a risk, you know, and just like myself, I take a risk every day I walk into my hospital, so I do the appropriate things. I wear a mask when I'm interacting with patients. I'm in full PPE when I need to be. I'm in moderate PPE, like a level 3 mask and gloves against everybody. It doesn't matter if you're there for a foot infection or for a cough with a fever. You treat everybody like you have an infection, plus I'm protecting them from me. So those universal strategies have worked very well within the hospitals. Same thing needs to go on in the schools. You know, the teachers have to protect themselves. They have to figure out ways of doing that. And it all goes back to the very remedial process of wearing a mask and staying distanced. If you can keep your distance from body, just like we're sitting here, you know, we're in an open air environment. We're probably 8 feet apart. We're facing roughly the same way. I'm sure no matter how bad my breath would be right now, he can't smell my breath and I can't smell him.
Yeah.
So we're not sharing the same air. That is fine, completely fine. There is no substitute for distancing. You know, whether you're indoors or out. Outdoors gives you a lot more leeway because you have a breeze and Mother Nature's on our side with this. Indoors it gets tougher, but it's not impossible. But if it becomes impossible, we gotta get close together, mask goes on. And we could be sitting side by side and I could be horribly infected and symptomatic. The chances of you getting it if you have your mask on and I have even a barrier mask on is still low risk. And that's lost on a lot of people because they think, oh, if this guy's got it, he's got to be in a bubble somewhere. Not really. And when we're watching kids populate a classroom and things, and you'll have positive test results in a kid who looks entirely normal. And we're seeing that. We see that across the country and across the universe at this point, which is great. And when a kid is symptomatic, get the kid out of there. You know, it's that simple. If you have somebody who's coughing, has a headache, has diarrhea, you assume that's COVID and you get them out and then you put them into the algorithm to say when can that kid return. Keeps everybody safe. Do we encourage people to be a lot more knee-jerk, let's get that kid removed from the situation? Absolutely. Because remember, we have really 1 full year to deal with this before the hope on the horizon would be a vaccine. And when the vaccines, plural, when they get here, and if we can get enough vaccination going where the herd immunity can become achievable in a matter of months instead of a matter of years, this thing, the infectivity of this goes down so low that it becomes more like a really bad common cold, particularly in this age group, in kids. It'll be a cold symptom, you know, moving forward. We're still going to have our old people, just a lot akin to like influenza. You know, you can get the flu, do great. You can get the flu and die. That happens every year. So we'll probably still see that definitely all through this year. Moving into next year, it's possible. Depends again on the vaccine rates and things until we can achieve the immunity broad spectrum. So and I think the schools are gonna be a lot, and I don't know, I haven't spoken to you guys about this specifically, about just how much leeway you're gonna give to teachers. My advice to teachers, if you have a comorbid condition, you know, if you, for instance, if you have your class seated, they are seated here, you walk in after them and you keep 8 to 10 feet of distance in front of them, and when class is over, you exit the room before they do, you're fine, completely fine. You know, if you're chair to chair, interacting face to face, touching, kids are in your lap, no one's masked, no one's doing what they should, you're putting yourself at risk. And that's just common sense. And again, all of this just boils down to just flat out, very simple science and very simple common sense. We just have to practice it. We have to not just know it, you gotta practice it.
Yeah, and I think we have encouraged those staff members who have those risk factors to reach out. You know, we have some options for our students that we will need staff for, and so, yeah, absolutely, great point. So, I'm looking at my list. We had a question from a retired teacher about asymptomatic children, which I feel like you covered it pretty well. We had an anonymous teacher ask, checking for fevers in children, it doesn't seem to address the fact that children are often asymptomatic carriers. I feel like you did a really good, is there anything else you want to say about symptoms and children? I think there was some questions about parents masking the fever symptom, especially with Tylenol. Let's go there for a second.
Sure, okay. Well, just to kind of go back and explain something, when people are symptomatic from an infection, okay, like a viral infection, the symptoms arise from the body's immune response to the infection, okay? So if symptoms begin on Monday of cough and headache and malaise, it's because your body at that point is mounting an immune response. So you are reacting to it, it's a foreign substance, we're creating these inflammatory markers, there's interleukins and these prostaglandins and this big response to try to fight this off. That's what makes people feel poorly when they have a bad cold or the flu or COVID. Right before that, the virus is in the body and it's interacting with those cells, it is escaping these people, they are viral shedding, and that's the presymptomatic phase. When we look, and if we hang everything on one or two symptoms, we're gonna miss a lot of kids in particular. This virus binds to a receptor called ACE2, and it is pretty much throughout our entire body, but its highest percentages are in the airway of the adults. There's a higher percentage in the GI tract in kids, so we see a lot more diarrhea in kids as a result of that predominance of this receptor in the GI tract. When it binds somebody in the upper airway and it gets into the epithelium of the pulmonary tree, it has to get out. So it gets out by exhaling, by coughing, by speaking loudly, by singing, by broadcasting material. So if we look at taking inventory of our kids, we need to look at all symptoms, not just fever. If we look across, and I've sampled both hospitals and everywhere that I can think of that's doing screening at the door, and I'm saying, what percentage of people are we picking up with the infrareds? Is it worth it or not? It's a good try, you know, it's an optic, it's a yes, we're looking for it. We're not seeing it very much. We're not catching, you know, catching a handful. It's like, geez, you have 100.9 temperature here, did you know that? No, not really. And we will catch a few people that way. You know, as far as a mass broadcast, is that really working? You know, efficacy is an argument. Because if you can state one, is that enough to keep doing it? You know, when you're sending your kids off to school each morning, we need to be looking at them. Use your dad's sense and your mom's sense to look and say, he doesn't look right. Taking temperatures is fine. Taking the inventory of symptoms, you know, does your stomach hurt? Do you have a headache? Do you have a sore throat? You know, we are seeing things like no smell. We saw today a hyper smell. Someone says, I can smell everything. It's crazy.
Huh.
You know, GI illness, nausea, malaise, decreased appetite, headache, body aches, you know, muscle aches, all of those things could be COVID, you know, and we all have this social responsibility to not send your kid to school if there's even a question of it, and to keep that kid at home and to think about it. I know there's built-in premises in your guys' plan about, well, she has allergies. It's just gotta be her allergies. That's great, so long as that is that child's MO and it's well documented and somebody can support that. But you don't want to, as a parent, say, this is just strep throat, they can go and I'll take them to the urgent care, right after school today, type of thing. And that hypervigilance is gonna have to carry through in this season in particular.
Yeah, so the follow-up question is right here. This question, as the parent of 5 children, 3 of which are in elementary school, our family will, as we do every school year, cycle through a lot of sniffles, colds, and coughs. Do we go to the doctor every time? Will we be missing a lot of class time for viruses that aren't COVID? Obviously, we don't want to be responsible for spreading any sickness, but we don't usually stay out of school for COVID quarantine lengths.
Correct. Yeah, no, and that's it. It's a great follow-up. It's a good segue into it, I suppose. Nothing else. I said this over the weekend to a group of people. Nothing else has changed. The entire world couldn't give a rat's butt about COVID-19. So rhinovirus is still here, adenovirus is there, allergies are still here, pneumonia is still here. Everything is still here, and everything is going to follow its own timeline. Influenza is going to follow its own timeline. Rotavirus is going to follow its own timeline. And that's some of that commonsensical, okay, we got to put the pieces together to see where we are. Luckily we have things like a strep test. Kid has a horrible sore throat, they go get a strep test, it's positive, they have strep throat. They don't have COVID. That's explainable. You have these cases where you're going to be able to say, yes, this is just this, or just this, and this is why. It's just allergies. We don't have any problems through here. And again, if you have a child with allergies, you send the kid to school with a mask on. If it turns out not to be allergies, and they're not febrile, they just have the sniffles, they're wearing their mask, kids around them are wearing their mask, except when they're socially distanced to the best of our abilities, the risk of transmission is really low. Whether it's COVID, whether it's rhinovirus or adenovirus or Coxsackie virus, you name it, we're slowing the respiratory transmission tremendously. So practicing those things will be of benefit. The case by case, how long do we leave these kids out of school? That's really going to be case to case, and it's going to have to look at exposures. Obviously, and the reason I say case by case, if we have a classroom that we know we have a positive child, and somebody sitting right next door is suddenly sick with the sniffles, probably going to have a lot more credence to say that kid needs to probably stay home too with the sniffles, even if it's allergies. Until we figure out, yes, that's just allergies, this kid can come back. So,
okay,
has to be looked at individually.
I'm just going to read these questions because I had them to ask you, but I feel like you've already kind of addressed them in your responses, just to have people hear their questions, I guess. So we know that the best 3 things to do is a combination of social distancing, masking, and hand hygiene. We also know that students will not be able to be distanced at all times. I don't think we've made the claim that they would. Is it safe for children to be masked, have sanitized hands on their way in and out of the classroom, which each one of our classrooms is going to have foam hand sanitizer, and we'll ask students and teachers to sanitize in and out. Is it okay to have those desks closer together than 6 feet and wear that mask? I think if you're willing to believe that masks hurt your oxygen level, we're not going to convince you otherwise. There's plenty of science out there that says they absolutely do not affect your oxygen levels. You're a doctor, you wear them all the time.
Yes.
For long periods. We're not even going to go there. But is 6 feet, less than 6 feet, masked, hand sanitized for a 45-minute class period in high school? Is that going to be okay?
Yeah, absolutely.
Okay, great. So
Absolutely.
that takes a parent question: how safe is it that there's no space to distance? What about kids who live with people over the age of 65?
Yeah, that speaks. It's a great question because in conversation with people, we look at really getting down deep in the weeds with what goes on between 8 a.m. and 3 p.m. The beautiful structure and the variable control of schools. At 3 p.m., it's Katie, bar the door. Now, you have no control over these kids. So you don't know what's happening with these kids after school unless they're in some extracurricular sports. But what happens in the school needs to carry forth at home as well. And teachers, I'm a teacher as well of sorts. We have to continue to teach our kids, these young people that are here waiting to be taught, about how this virus is spread and about their own responsibility moving forward, so they can go home and teach their parents about social distancing and about hand washing and hand hygiene. If kids are here and they're learning those good practices and can take those home and impart it to 5% of the population, well, that's a win. You know, we'll take that. What happens outside of the school is only as good as the parents at home. And if a parent at home is a comorbid parent, meaning or grandparent or great uncle or whatever, if you have diabetes, if you have heart trouble, you need to not put yourself, you are in charge of yourself. Don't put yourself in a bad situation. So if you think, well, I'm gonna go over and I wanna visit, you know, with these kids, they've been in school and their school has 2 or 3 positive cases, probably not the best idea for that adult, but the adult makes that decision. We are not inoculating kids and sending them into a dangerous environment. Okay, they are not our Trojan horse to infect everybody with COVID-19. So everybody outside of the school has to be diligent and has to be responsible for themselves. Make good decisions at home. These kids, when they leave here, they need to be taught, make good decisions when you're not at school.
Well, and I think that speaks to why I think we've worked really hard to provide a couple of different at-home options for kids who maybe, you know, a parent or a grandparent that lives in the home or an older adult that lives in the home not comfortable with sending their child back. You know, we now have significant options for that child to still get an education from home, and I think that
absolutely, that option is always there, and it's always there as well if we have to hit the pause button. If something happens, we have to hit the pause button for a while, whether it's a day or a week or 3 days or whatever it is. Those preparations have already been discussed, already been put into place, and I've spoken to a lot of parents who said, I'm just not comfortable with my 14-year-old going back to school. We're gonna do virtual. That's great. That's why that option is out there.
Yep.
They're not being deprived of an education, and you know, I applaud the school systems. Not only this one, but the entire state has virtual options set up at this point. And some of which have elected, we're gonna go virtual only. That's entirely up to them, and it's in relation to their own demographics and their own capabilities. I think this plan is best for Vigo County.
Okay. So I want to close with some teacher questions. We got this question from Michelle Francis. As an educator, I'm worried about a lot of things. However, I wonder about bringing the virus home on my clothes or shoes. What's the best way to do my laundry? Is washing garments on a cold cycle and hanging to dry okay? Should I wear different shoes home? I've read where some people suggest putting a towel on your car seat is a good idea. Do you agree?
Okay. It's a great question. And when I'm going to give you, I know I'm long-winded, I apologize.
No, that's okay.
I'm going to midnight.
You've hit a lot of the questions, so.
When this first came and it befell me at the hospital, the vigilance that went out, I mean, for myself, I mean, I had a separate dressing area and a separate undressing area and right to the shower, and my wife and child went to the other end of the house, and I slept in my own bed for a long period of time because of the unknown, to figure out how do I interact with the virus. I'm with the virus every day, you know, occasionally we won't have a COVID patient in the hospital, but most part they're there. So I see it, and I know it's in society. How to interact with it is a comfort level as you move forward. The virus will survive on a surface. If I have it and I sneeze, it's going to be on this non-porous surface. If I sneeze onto carpeting or onto clothing, it's going to get absorbed by the material. And I know that your guys' strategies are remove clothing or soft chairs and those types of things. I worry less about the soft materials than I do a hard material, simply because if I sneeze into my shirt sleeve, it has to get from my shirt sleeve and into another person. How's it going to get from my shirt sleeve into another person? Somebody would have to come and touch my shirt sleeve and then immediately go to their face. If it's here, it's a lot more innocuous. You know, if it's on a hard surface like this, you can come by and now my hand's in it, don't know it. Now my hand itches, now it's on this finger, now it's in my nose. Very simple. So when you're talking about things like washing your clothes, you could be diligent. What I do when I leave the hospital is I bring a change of clothes with me, and I put all of my dirty scrubs into a bag. I do my own laundry with that on hot. We want hot water, not cold water type of thing. I do leave a pair of shoes at the hospital, but that's a practice I've done for a long time. Okay, hospital floors are not a very clean place, obviously. So, you know, you can be as diligent as you want. Don't make yourself neurotic with it, because this virus, although it's somewhat hardy, it's easy to kill. It's easy to kill with soap and water, hand sanitizer, Clorox wipes, homemade bleach water, alcohol, it doesn't really matter what it is. It's very simple to control and contain. And the premise of keeping your hands away from your face when you're doing cleaning is of paramount importance, because if I lean on this desk while I'm wiping off another, and then I go to my nose, I've disinfected myself potentially. Still a low-level risk. Fomite transmission is losing traction as far as this is how people are getting it. It's more those symptomatic and pre-symptomatic people that are spreading.
So, we've gotten a lot of Clorox wipes. I won't tell you where because I know they're in big demand, but we have a lot of Clorox wipes for our buses and our schools. We've got the spray from Eco Lab that, every day in the elementary school, we're spraying all the hard surfaces down, and in between classes, we'll be, disinfecting as much as we can in middle and high school. It sounds like the hard surfaces are the thing to really focus on.
Yeah, absolutely, absolutely. Hard surfaces, common surfaces. And, by the converse argument, this is maybe the safest school year we've had because of all the cleaning that's going on. Because, you don't clean when we don't have COVID nearly as much. Granted, people will do their part. But rotavirus, for instance, that causes diarrhea in kids, it's fecal oral transmission. So that's fecal contamination of products that get into kids. So it's gross, but that's how it works. Those types of cleaning premises, just hard surface, wiping them down, being diligent about hand washing, that's going to reduce all transmissible disease.
This is a question, and special education is a big concern of ours at the school corporation, just because so many of the services that our special education children receive, they're best received in an in-school setting. So this is a question from Shelley Toon, a teacher. She says, I'm a teacher in an elementary functional curriculum classroom. My students require assistance to complete personal care tasks, activities of daily living, and to participate in classroom activities and instruction. I also have some students that I know are coming back to school with mask exemptions. What should my priorities be in order to provide the safest environment possible for students and staff?
Okay, it's a great question. As a medical professional, I have concerns too about special education kids and kids with special needs in general. The best way for Shelley to address it is to think about those children, what their needs are, what she does outside of her job, making sure that she's not bringing COVID to that child. So, distancing at home, wearing my mask in public, making sure I'm not sick. Don't cut any corners with that. From the kid transmitting to her, it's going to be secretions. It's that up close and personal. Kids need tactile stimulation. They need a quick hug. They need a squeeze here or there. They need, helped in and out of a chair. They might need help with a medication administration. If you can keep interactions brief rather than prolonged, that helps. If you, the teacher, can wear a mask, at all costs do so. Because that's going to help protect you to some degree from that child, and that child from you, most importantly. So if you can wear a mask, that's great. If you have a kid who, maybe has a pervasive developmental delay, doesn't react well to the visual concept of a mask, a clear face shield is better than nothing. It does not stop particulate matter to come down the front of you, but at least it stops the direct transmission. So think about creative ways to limit the interaction face-to-face for prolonged periods. Even if you have to go back and forth, it's better than not. If you have aerosol-generating procedures on a lot of kids, they need nebulizer treatments. That escaping aerosol, treat it like it's contaminated air. Don't let it get ingested into your body purposefully. Do your part to stay away from it. And even in, if I'm interacting with a special needs child, and I'll use my mask as their face, rather than being right here like this, you could put your face on the outside here and talk to that child in the ear, okay? And to be able to soothe that child, whatever needs to be done, give instruction, without letting that direct line of particulate matter be right there. So it's just little nuanced types of hints just to help keep, if you can smell the breath of a child, you're too close to that child. If that child can smell your breath, they are too close to you. So distance yourself, block the transmission.
So I had another question from Sarah, who's a teacher, about using face shields rather than masks. you kind of hit on that, why we're saying masks, not face shields,
Right.
because it can still come down the front. It's just not as safe as a mask.
Exactly.
Okay.
Yeah, it's definitely, you are sacrificing a lot by wearing a face shield.
So the last question I have for you is also from a teacher. It's from Mary DeBard. What precaution do teachers need to take if we have students hand in papers? Should we leave them sit for 72 hours? What about displaying papers in our classrooms or in the hallways? Talk a little bit about papers as a surface.
Yeah, okay. So papers in general, certainly laminated surfaces are non-porous. You can do things to wipe those things off if you have something you're going to be passing around. Anytime you handle a common object, if you need to pass things around, try to limit that as much as possible. But if you have a laminated surface, you want to wipe those down as much as you can. If people have regular old paper and they're handing in papers, the onus falls on the teacher, or whoever's receiving those. Not so much from the kids giving it to the teacher, but if I have a stack of sheets, from returning from a test, and I need to handle that, the first thing I'm doing as a teacher is I'm putting on my mask, okay, and I'm going to put it on for demonstration purposes. Now, I've got my hand sanitizer, my hands are clean, I go through all of the papers. If I forget and I touch my mouth, my mask is here to help protect that, okay? I just stopped from going to my face. It doesn't stop my eyes, okay, and that's where a face shield or wearing glasses or being cognizant of it. But if things get on your hands and you take them to your face, you could potentially inoculate yourself. The risk of transmission seems to be very low, okay? It's not 100% this is going to happen. But it's also not impossible. So if the teacher wears a mask, gets through the papers, my job is done. Papers go here, more hand sanitizer for a good cleansing or warm soapy water. Mask comes off, I'm back to usual, okay? No risk there at all. What happens to those papers at that point? Completely variable. If you're done with them, stick them somewhere. It doesn't matter. If you need to redistribute them, is there value in leaving them in a space for 24 hours? I mean, theoretically, is it plausible? Probably not. It's probably okay, that's not going to just jump off of that paper and get in somebody's face. But you just got to be diligent with it and just think, all right, best case scenario, what if I take an extra step here, on the side of safety? Just go that route. But the teachers should protect themselves, and the mask is the easy way.
Okay, great. Well, you had a 12-hour shift today. I added 47 minutes onto the end of that.
It's all right.
I really want to thank you for your candid responses. This was a good group of questions that represented about the 70 questions that we received, and obviously we couldn't get to all 70, but I think parents and teachers and community members have some tough questions, and I hope today's conversation went a long way to answering those.
I hope so. I was trying to be as open and candid as possible. And, the honesty of this is that I do have a high degree of confidence that kids coming back to school is going to be okay. I'm lacking in some confidence in society in general because of the rate of increase right now of our cases. That is not school related. So this is going to be an additive or cumulative effect. And this is parents are community members as well. These kids are out there as well. They have older siblings. So what is learned from this return to school program, the mitigation and the distancing and the masking, being extrapolated in the community is incredibly important. Particularly if we have people in Washington or in Indianapolis who are watching these data points to say, we're going to determine everything on a data point. We got to do everything in society in order to keep things mitigated and minimized. And part of it, like I said, it all boils down to really just common sense and understanding the generic principles of my water bottles, that if we can keep the infection isolated, don't spread it around, all of this can burn itself out over time. But we can't just not understand it, we have to enact it. We've got to follow these principles. So teachers, take the opportunity, please, to teach these kids what to do and what to do when they leave the classroom. And take the opportunity to continue to educate parents as well and yourselves, because you have other kids. Your kids have already graduated, but they're still listening to mom and dad. So everybody has to parent. Kids, you got to go parent your parents, because they're not doing what they need to do in society all the time. So it's a broadcasted message, but I think it's very much doable if we control the variables.
Great. Well, thank you so much for your time, and this will be archived on our YouTube channel, so encourage folks to share it, good information about school reopening, and we can't wait to see our kids again. So thank you very much.
No problem. Well, thank you for having me, and best of luck with the school year, and I won't go and hide from this either, so if people have more questions, I'm happy to answer it until I'm exhausted and fall on the floor. So,
Great. Well, I'm going to walk over and shut it off, so it'll be a little awkward here, but
yeah.
thank you.